So again, welcome all. So keeping in line with our patient, Miss Yuan Lee, this is our 28-year-old patient who is now pregnant. She was planning pregnancy during the module 1 to 4, and now she's pregnant and she's 32 weeks of gestation. If you remember her case, she actually emigrated from Taiwan when she was 2 years before her birth, and her parents are from Taiwan. And when we screened this patient, we saw that the patient was hepatitis B surface antigen positive, core antibody positive, and surface antigen, hepatitis B surface antibody was negative. When we did additional serologies, we saw that the IgM component of the hepatitis B core antibody was negative, E antigen was positive, E antibody is negative, and the DNA level is 1.1 million. She has normal ALT. So now she comes to our clinic and we need to decide what to do with this patient, right? Does anyone have any thoughts at this moment, or does anyone want to share any cases at this moment? I'm gonna wait 10 seconds to see if anyone is interested. And again, just a reminder, you guys can actually chat into the group chat if you have any questions, or text it into the group chat. Okay, so as our audience, you know, they're in primary care and some of them are in GI and hepatology practices as well. So mostly if you're in the primary care or in the liver practice, you see these kind of scenarios quite common, hepatitis B and pregnancy. So if you remember our slides from module 1, chronic hepatitis B sets itself as a chronic infection if the fetus or the newborn gets infected early on. And the reason for that is during the pregnancy, in the host, in the mother, the immune system is modified to tolerate the fetus. And that's how mothers don't reject the fetus and they carry out to the full gestation and deliver. Now, during this time, there is a lot of immune priming that occurs. This is typically through the macrophage and activation of the T cells, but this is not through the B cells, which typically produce the antibodies. Now, there is also enough evidence that's available in the literature that CXCL3, which is one of the important receptor, it gets expressed in the liver macrophages. This happens typically at birth, okay? And this expression is very ineffective, and as the child becomes an adult, it becomes more and more competent, and we have the capacity to develop antibodies to infections. So because this expression is kind of ineffective at birth, if the child gets infected with hepatitis B, there is no way to eradicate that hepatitis B, and that virus basically sets in as a chronic infection. Now, these are some of the mechanisms in which we know that the viral dynamics play in the age-dependent clearance or persistence of hepatitis B. Okay, so again, if you remember, chronic hepatitis C, more than 90% if the child gets infected below the age of 5 years, okay? If you get it as an adult, the chronicity rates is almost close to 10%. 90% of the time, the adult would be able to eradicate it. So when we talk about vertical transmission or mother-to-child transmission, which you can see in many of the papers written as MTCT, that stands for mother-to-child transmission, vertical transmission can occur at stages of pregnancy. It can happen through the gametes, okay, through the germ cells. It can happen via the placenta, or there is intrauterine transmission of hepatitis B. There's also perinatal transmission of hepatitis B, which happens around the time of delivery. So if you look at the evidence, and this is one of the current hepatology reports that me and Dr. Pan from New York, we both did a review. This is published in 2018. We have shown in this paper that individuals, hepatitis B is found even in the spermatozoa, even in the oocytes of patients who actually develop chronic hepatitis B later on after pregnancy. So there is good enough literature to support all of this. Now, most of the time, the hepatitis B transmission happens around the time of delivery, okay? And this is typically when there is blood-to-blood contamination, there is rupture of membranes, which is when the mother's blood gets contaminated with the fetal blood. So as you can see here, E antigen, it is small and it can pass through the placenta. E antigen and surface antigen, they can transmit throughout the time of delivery, especially in the perinatal periods. And even in younger children, if the child doesn't get immunoprophylaxis, this is immunoglobulin and vaccination, they can actually get postnatal transmission, especially from mother to child, due to close contact. Again, you would typically need blood or body fluids for this to happen, but these are different ways where we can actually cut the life cycle and prevent the transmission. So what do we do to create steps where we can identify individuals who are at risk? Well, all pregnant women, they should be screened for surface antigen. And this should be done as early as possible. The moment if you identify a patient who is at risk for hepatitis B, they should get screened for surface antigen. Once the surface antigen is done, we should assess, if it is positive especially, we assess the liver function and liver fibrosis, again, as early as possible. And this can be done via just the blood tests. With the blood test, we typically look for platelets, albumin, and some of the other liver function to tell us whether the patient has significant liver disease or not. Ultrasound definitely helps. And again, there are multiple non-invasive markers of fibrosis, which we discussed in the prior modules. Now, if the patient is surface antigen positive, we need to check for ALT, E antigen, and DNA as close to third trimester as possible, because this is the time where we can actually intervene. This is typically with antiviral therapies, and we can actually curtail the vertical transmission. Now, you may ask, why not give antiviral therapy at second or first trimester? Well, at first trimester, there is organ formation, so therefore we tend not to. But we know that there is enough literature. So if someone is already on antiviral therapy, especially like in the HIV population, these antivirals are actually safe. You can actually continue throughout the pregnancy. What we're talking here is specifically if someone is not on antiviral therapy and you want to prevent vertical transmission, that is the kind of scenario when we test for these blood tests close to the third trimester. And again, very important is we need to closely monitor the ALT and DNA after postpartum, because that is the time when there is a high risk of reactivation of hepatitis B. We'll go into that in the next few slides. So obstetric interventions. So we know that the more there is instrumentation or interventions during the gestational period, the risk of mother-to-child transmission is high. Now again, some of the times you may have to do this because if the patient is suspected to have, or the fetus is suspected to have Down syndrome or any other congenital abnormalities, well, amniocentesis or chorionic villus sampling are important to figure that out. But one thing that is important to note is amniocentesis or CVS, this is chorionic villus sampling, this increases the risk of vertical transmission by 50%. And this is much higher in mothers who have a hepatitis B viral load more than 7 logs. So again, we need to really be careful. If the mother has very high viremia, these procedures are, they do cause increased risk of vertical transmission. And the best thing will be, if it's appropriate, we should start the mother on antiviral therapies and, if possible, avoid these cases. Now, cesarean section, you can see that multiple papers have actually showed conflicting results. But the most recent ones actually show that cesarean section, especially prior to the rupture of membranes, can be a bit safer. Okay. So again, the only reason hepatitis B should not be the only reason to determine whether cesarean section is the right way or not. Okay. But clearly it has been shown that in highly viremic mothers, if you do cesarean section, and again, this is not emergent cesarean, this is elective cesarean prior to the rupture of membranes, there is data to support that the vertical transmission rates are a bit lower. Now, we know that hepatitis B DNA is found in at least 52% or so of vaginal secretions. And again, if there is rupture of membranes and other things that happen during the birth, these secretions can contaminate and result in vertical transmission as well. So how can we prevent this in the child? Well, we can give hepatitis B immunoglobulin. This is immunoprophylaxis. So immunoglobulin plus hepatitis B vaccine given within 12 hours after delivery offers the greatest protection. Okay. So if you look in the table, E antigen negative mothers and surface antigen is positive, and the infant, whether the infant gets vaccination or not, the risk is less than 5%. Whereas the vertical transmission risk can really, really go down on almost negligible rates if the infant gets the vaccination. So therefore, we do recommend vaccination in E antigen negative. Now, the biggest risk factor is in E antigen positive mothers, because E antigen positive equals very high viral load. So if the infant doesn't get any vaccination, you can see that the risk of vertical transmission is more than 90%. Now, if that individual, that newborn, get the immunoglobulin and the vaccination, the chronic hepatitis B rates can be 10 to 15%. So again, you can really, really minimize that risk. Now, can you minimize the risk lower than 15%? The answer is yes. So stay tuned for the next slides, how we can reduce that risk in E antigen positive mothers. So like I said, maternal hepatitis B treatment. So this is a mother who is not yet on any antiviral prophylaxis. So if she has more than 8 log copies, this is associated with the highest rate of transmission. But you can see that even if the hepatitis B viral load is a little bit lower, 6 to 8 logs, you can still see that the transmission rate is up to 6%. So this is typically the case in E antigen positive mothers. So how can we reduce this less than 15% of transmission? Well, if you treat the mother with antiviral therapies. So we do offer all mothers who have a hepatitis B viral load more than 200 international units to get antiviral therapies. Now, the only antiviral therapies that are safe in pregnancy are lamivudine, telbuvudine, and tenofovir. Okay, so other than these, you don't have pregnancy-safe antivirals. And of all these three, you know that from the prior modules, lamivudine and telbuvudine are not really first line, and therefore tenofovir will be the first line agent to go, or preferred choice to treat mothers with very high virus. So who are what is the ideal situation where you can offer treatment? Well, tenofovir is the best, like I already said. And any mother with a viremia more than 200,000, they're the ones who are indicated to receive the treatment. Now, tenofovir is effective even if we know that the mom was previously exposed to lamivudine or she has resistance to telbuvudine. Now, these are some of the agents that we don't use, at least telbuvudine, we don't use it here, but if you go to other parts of the world, like in China or Southeast Asia, you can see all the variety of antiviral therapies being utilized. Okay, so it's important to know that even if you have the resistance to the second line agents, tenofovir is still safe. Now, what we also kind of debate about in our liver meetings is that there is a small risk of exposure of tenofovir if you give it during the first trimester, which can actually cause mitochondrial toxicity and potential damage to the fetus. So again, this is one of the reasons why we do not continue or we do not recommend starting of the antiviral therapy at this time. So the ideal timing really is in the third trimester. The best time is really 30 to 32 weeks of gestation. Okay. Now, if the mother has cirrhosis due to any cause, and also has hepatitis B viremia, the mother should actually initiate antiviral therapy as soon as possible. Because again, during pregnancy, if there is a hepatitis B flare, that would basically cost the mother's life and also the pregnancy. Okay. So again, we want to avoid flares, we want to avoid maternal decompensation during the pregnancy. And again, maternal fetal outcomes are much better if you actually treat mothers with active viremia. Postpartum management, like I said again before, there is a risk of flare right after delivery. There is a huge immune reconstitution that happens. So all the immunologic changes that are favorable to maintain the pregnancy are already gone, which actually leads to a state of immune reconstitution. So that is responsible for the flares. We have sufficient evidence to actually recommend, without any controversy, that breastfeeding is totally okay. It does not increase the risk of hepatitis B transmission. Okay, so the only time we actually counsel mothers is if they're on antiviral therapy and they don't want to stop it. Some of the medication, especially tenofovir, can be secreted in small doses in the milk. And if the baby gets breastfeeding, then there is a small risk of interference with bone health in that fetus. But again, more and more evidence actually suggests that may not be the case. Okay, but we do have to counsel mothers. They have to know about that small risk of bone health being a problem. Okay, so hepatitis B infected pregnant women who are not on antiviral therapy, we typically recommend you can stop the treatment at or very early after delivery, typically between 2 weeks or so. And after that, they can actually start lactation, and they should be closely monitored because of the risk of hepatitis B flares. So these are some of the slides that will kind of guide you through how to prevent perinatal transmission of hepatitis B. So again, when a surface antigen test is available and the woman comes to you for the OBGYN management, you basically look at the maternal surface antigen test. If it is positive, we need to place, the positive test result in her chart. We need to make sure that the infant gets immunoprophylaxis, because that's really the only way we can prevent the infant from getting vertical transmission. And again, the dosage of immunoglobulin and hepatitis B vaccination are here. If surface antigen is negative, we basically look for, does the mom have high risk factors? This is typically if she ever had a sexually transmitted illness, if more than 2 sexual partners, injection drug use, and if the father of the baby is surface antigen positive. Again, if that's the case, you retest for hepatitis B surface antigen in the mother, because again, there is a risk for developing hepatitis B anytime during the course of delivery, okay, anytime during the course of the pregnancy. And if she's positive, we follow the algorithm in purple. If the surface antigen is negative, we still recommend just the hepatitis B vaccination for the baby. There's no reason to give immunoglobulin in surface antigen negative mothers. The next few slides will basically show how to prevent hepatitis B vertical transmission when surface antigen test is not available. So again, we don't know what is the surface antigen, and if the baby weighs less than 2 grams, we typically look for maternal hepatitis B surface antigen results. If it's positive, we give both immunoprophylaxis with immunoglobulin and vaccination. And if surface antigen is negative, the baby just gets hepatitis B vaccine. So again, this is kind of a algorithm how to manage hepatitis B during pregnancy. If you see a surface antigen positive mother, we basically assess hepatitis B stage. We assess the liver function. We assess whether mom has cirrhosis or not. Now, if the mother has advanced fibrosis, ALT is more than 2, then typically this patient or you need to treat the maternal viremia with an antiviral therapy. Typically, the one that is recommended is tenofovir. That's a first-line agent, and it's also safe during pregnancy. Now, if the patient is on any of the second-line medications like telbivudine or lamivudine, you can basically check if these medications are controlling the hepatitis B or not. If the virus is undetectable, then you can continue these medications throughout the pregnancy because they're safe. Whereas if there is any positive virus, we need to switch to tenofovir because tenofovir will combat resistance to lamivudine and telbivudine. Now, if the mother is not on any antiviral therapy, we need to check hepatitis B DNA close to 3rd trimester. And if the DNA is more than 200 international units, we should initiate tenofovir. And again, we monitor ALT, we monitor DNA very closely, close towards the delivery and after the delivery. When we talk about hepatitis B reactivation, this is a very common clinical syndrome. If you do not test for hepatitis B during the pregnancy, again, after delivery, there will be an immune reconstitution syndrome, and there will be several serologies and ALT that becomes positive due to the viral flare. And sometimes it doesn't remain silent. It can actually lead to acute liver failure. And once the mother actually gets to acute liver failure, transplantation will be the only option. Starting treatment at the time will not be sufficient. Okay. And again, like I said, very close follow-up is required to monitor for hepatitis B reactivation flares around the time of delivery. So these are some of the AASLD criteria and generally accepted criteria. So whenever we're looking for a flare, we look mainly for hepatitis B DNA from the baseline. So that typically gives a clue whether there is a viral flare. We can also see that reverse seroconversion can happen around the time of delivery. So even if the patient has core antibody positive and surface antigen negative, that can turn into surface antigen positive. So again, we need to mainly look for these kind of reactivation. And viral reactivation may or may not lead to hepatitis flare, which is why, again, we need to closely monitor these patients. And once the ALT goes more than twice the upper limit of normal, these are the patients who will actually require treatment, and we need to prevent these hepatitis flares. So that's all about hepatitis B and pregnancy. I'll take a brief pause to see if anyone has any questions.
Ram, I think we had a comment. So I don't know if it was necessarily a question. It said from 933168, I'm not sure who that is, but it said that looks like immune tolerant patient at 32 weeks of pregnancy and high HBV DNA, i.e. transmission risk is high. I don't know if you wanted to address that.
Right. So yeah, I don't know who she is. If I can address her, I would. But clearly, this is about our patient that we discussed in our vignette. This is UN. Okay. So she's 32 weeks pregnant, hepatitis B viral load is very high, and ALT is normal. So this is our classic immunotolerant patient, right? So if you go to our algorithm again, okay, so this is our algorithm, right? Rachel, can everyone see?
No, I don't think we can see it, Ram.
No? Hold it. My bad. Share.
Yep,
Now?
we can see.
Okay. So if you look on the left side of the screen, the audience member who actually pointed out correctly, mother has surface antigen is positive. She's e antigen positive as well. And the DNA, when we check at her 32 weeks gestation, it's clearly over 200,000. So this is a situation where there's vertical transmission. Therefore, we should initiate tenofovir in order to prevent the cycle of vertical transmission or mother-to-child transmission. Okay, and once we begin the antiviral therapy, we counsel these mothers and we typically ask them to have a stoppage around the time of delivery, about or 2 weeks, and so that way they can actually breastfeed. Okay, and once the lactation is completed, we can then again closely monitor their ALT, and based on their clinical status, we decide whether she needs to resume treatment or not. But clearly, starting antiviral therapy in the mother, and also the second important step is to give immunoprophylaxis, immunoglobulin and hepatitis B vaccine to the fetus, to the newborn. Both these steps are important. Okay, so thank you for pointing it out.
Yep. And Ram, I don't know if you want to address this other question Aileen had right now. She said, I have several patients who are on Truvada for HIV pre-exposure prophylaxis. Some of them have chronic active hepatitis B, all are at risk. Many have on and off adherence with Truvada. How risky is this in terms of risk of with on off Truvada use? Are they at risk of hepatitis B flare?
Right. So again, we're talking about a PrEP schedule versus hepatitis B treatment. Okay, so someone who has chronic hepatitis B, if they have surface antigen positive, they should be on an antiviral therapy. They should not just get PrEP, right? PrEP is only for individuals who do not have hepatitis B, and you're preventing a HIV transmission. So in such individuals, actually, you should consider giving them Truvada daily. So this will actually prevent HIV transmission, and this will also keep the hepatitis B under control. Okay, so they should not be on and off PrEP. That's the skinny recommendation, skinny version of it.
Ram, 933618 had a follow-up question. The questions prior to the one we just discussed. How long antiviral meds, how long should you continue antiviral meds after delivery? Okay,
so that's a good question. So again, your indication to treat the mother should be, is this to prevent maternal transmission, mother to child, or is this to treat the chronic hepatitis B in the mother? Okay, so our patient, for example, I'm putting it in context, Miss Yuan, she's about 28 years, right? She doesn't have the high risk features to develop cirrhosis or liver cancer based on the age, okay? Remember when we talked about immunotolerant patients who actually have high risk of cirrhosis and HCC, these are the ones who have high viral load, but they should be typically over 30, typically men, typically in the Black ethnicity. So those are the factors where it becomes higher, where you want to treat the mother. But if your indication to treat is just to prevent maternal to fetal transmission, I think you can actually stop around the time of delivery and watch. At any time, if she shows features of chronic active hepatitis B, where ALT is elevated and she also has signs that her liver disease is progressing, well, you have to treat the mother. Okay.
Thanks, Ram. I think that's all our questions so far. So if you wanted to continue.
Okay. So this will be, I'm still sharing the screen, correct?
No, we don't see anything yet.
Uh-oh. Okay, share screen.
Yep, we're good.
Okay. So,
Great.
yeah, following up with module 5, this is the second part of special populations. This is hepatitis B risk in immunocompromised individuals. So when we look at the risk of hepatitis B flares, we look at the host. So again, how the LFTs, what's the underlying illness of the patient, and we look at some of the viral factors and medications as well. Okay, so it's a combination of all three. The more intense the immunosuppression is, this is typically high-dose steroids, anthracyclines, stem cell recipients, rituximab, and duration of immunosuppression. So all these factor in from a immunosuppression standpoint. The more intense they are, the higher the risk. From the viral load standpoint, if the patient has surface antigen positive, if the patient already has high viral load, if the patient has e antigen positive, pre-core mutant, or other mutants, and surface antibodies in low titers, these are the viral factors that tell us that this patient has high risk of reactivation. And again, when you look at the host factors, especially if the patient already has cirrhosis from other causes, if the patient already has elevated liver enzymes, or if the patient's underlying illness is too bad that any small flare can actually make the patient succumb, they will also play into the risk for hepatitis B reactivation. So again, to put it all in perspective, Morianne, for example, she deals with a lot of patients in IBD, so anti-TNF inhibitors. So if you look at these kind of medications, you see that anti-TNF is causes moderate degree of immunosuppression, whereas the severe forms of immunosuppression or intense immunosuppression will be right after a bone marrow or hematologic transplant or after a solid organ transplant. If you look at the other agents, anything that ends with B-cell depleting agents or anything that ends with rituximab or monoclonal antibodies, they typically increase that risk. High-dose steroids, local therapy for liver cancer, this is HCC, TNF inhibitors or IBD or psoriasis medications, they all increase to a moderate degree. Systemic chemotherapy is next from the lower end of the spectrum. And antimetabolites, this is 6-mercaptopurine, azathioprine, methotrexate, CellCept, they basically are considered antimetabolites and their degree of immunosuppression is lower end of the spectrum. So higher end, more viral load or surface antigen positivity, the risk for reactivation is high. So these are AASLD recommendations for patients who receive immunosuppressive or cytotoxic therapies. So all candidates who get this should actually be screened for core antibody, surface antigen. And I would actually add surface antibody as well, because if they're negative, you can give them a vaccination. But the reason why they didn't add it here is if they're already immunosuppressive, they may not mount a surface antibody. Okay, but regardless, you can give a trial of vaccination prior to their chemotherapies. Now, if the intensity of immunosuppression is too high, the presence of surface antibody does not prevent reactivation. This has to be kept in mind, especially if you're administering B-cell depleting therapies like rituximab. If the patient has core antibody positive and surface antibody positive, that does not mean the patient is protected. This surface antibody titer can wane off, and that can lead to reactivation of hepatitis B. So again, from cancer therapies, this is all evidence that we have so far. We see that up to half of the patients with surface antigen positive can develop reactivation. If they're surface antigen negative and core positive, the risk is still high. 1 out of 5 patients, up to 18%. Now, the risk is much, much lower if the intensity of immunosuppression is less. So if it's all anti-rheumatic therapies or anti-TNF factor therapies, the risk of reactivation is up to 12% in surface antigen positive, and it's almost 1% to 2% in surface antigen negative patients. So clearly, surface antigen positive patients, even if they get lower intense immunosuppression, they should be treated for hepatitis B. So in surface antigen and core antibody patients, like we talked about, the typical anti-hepatitis B prophylaxis should start at least 2 weeks prior to the beginning of immunosuppressive therapy, and should continue at least for 6 months after the stoppage of these therapies. Okay. Now, if these patients typically show signs of chronic active hepatitis B, they should ideally be left on the treatment. And what do you treat with? Again, clearly, we need to treat them with first-line agents. We need to use entecavir, tenofovir, either disfumarate or alafenamide. Okay, so that's TDF or TAF. Because again, back in the previous talks, we talked about the barriers of resistance. So entecavir, tenofovir, both of them have very high potency and very high resistance barriers. In surface antigen negative and core antibody positive patients, again, if you're not thinking of treating them, these patients should be closely monitored with liver function tests and DNA, and at any time, if they show signs of reactivation, they should be treated. A little bit about Delta infection. In Miami, we don't see that much of hepatitis Delta, but we know Eileen is from New York. So New York, Chicago, California, these are some of the areas in the US where we actually see very high rates of Delta. I actually had a cohort of about 6 to 10 Delta patients in New York. So again, we read about this in medical school. We may have forgotten about Delta, but Delta is very much present. Okay, you just have to look for it. So to kind of recap about Delta, it's a defective RNA virus. This belongs to the Hepatina family. It cannot exist by itself, but it needs hepatitis B in order to replicate. The incubation period is up to 2 months. And if you look at the type of infection, it can cause superinfection, meaning the patient already has hepatitis B, they can develop Delta during their lifetime. And typically that causes worse prognosis because 80% of the time it's chronic and it causes more severe disease. The other scenario is it can occur as a co-infection, meaning Delta and hepatitis B get transmitted at the same time. And this typically is seen in patients who have homosexual men, IV drug users, post-needle exposure. So these are the times when they get both viruses at the same time. Again, these are blood-borne viruses, so you expect the transmission to be parenteral. Diagnosis, we actually look for antibodies, IgM, IgG, and RNA of hepatitis Delta. And typically, sometimes we actually find this on liver biopsies as well. If you look at clinical presentation, it's typically self-limiting. It causes chronic hepatitis or fulminant failure as a superinfection, but as co-infection, most of the time, Delta gets under control. The only treatment that is available is pegylated interferon, which we give for up to 1 to 1.5 years. There are new medications which are actually in the pipeline. There's a big multi-center trial that's going on in US using interferon plus other microRNA inhibitors for hepatitis delta. So if you have one, you need to refer them to the closest tertiary center.